Hey everyone, welcome back to the channel. I have Andy with us again. You've seen his face before. Hi Andy, how are you?
Hi, Khara. I'm good. Nice to see you.
Nice to see you. I'm feeling so grateful that you're willing to talk about something kind of changing in the Medicaid community. And so we're going to dive right back in. So if you want to introduce yourself and jump into the content, I'm happy to go there with you.
Okay, super. I'm Andy Rose. I'm the director at Boulder Emotional Wellness, which is a Medicaid outpatient psychotherapy clinic, and we serve the Boulder, Denver community, and also statewide through telehealth. We have about 50 clinicians right now, and I also am the committee chair for the data committee for Combine, which organizes Medicaid clinics. And I have the good fortune to have license number one for the Essential Safety Net provider program. And so I want to help everyone understand like what we're signing up for when we become an essential safety net provider.
That's right. Yeah. So some people are like, what the heck does even this mean? Like they've never heard this before. I know a lot of us are trying to track all the info. So very grateful that you're going to help us unpack this a little bit. So if there was a short definition of what an essential safety net provider is or does, what would that sound like to you?
So the safety net program is a behavioral health administration program. So not well, in part administered by HICPUF and the regional accountability entities, but mostly driven by the behavioral health administration in terms of writing rules to comply with the law that created the behavioral health administration. So there are two types of safety net providers. There's comprehensive safety net providers that provide 9 enumerated services, and essentially the historically called centers, which were CMHCs, community mental health centers, are now kind of relabeled C-SNPs, comprehensive safety net providers. There's also the essential safety net providers that provide one of those 9 services or more. And one of those 9 services is outpatient psychotherapy. So a safety net provider, an essential safety net provider provides one of the services like mobile crisis or outpatient. And Essentially small clinics, solo operators and small clinics and independently contracted clinics can become essential safety net providers and receive a higher reimbursement in trade for some additional work. And so the main thrust is social determinants of health, or what we call health related social needs, and how are we going to screen our clients for health related social needs, and then how we're going to refer them to helping organizations. And then even a little more complicated is what's called closing the loop. So closed loop referrals involve understanding what happened when the person went to the food bank or when they went to get utility help or housing help, what their experience was, and if they engaged with the helping program, and or if they completed a program. For instance, they can be referred to educational programs. So what the Behavioral Health Administration is asking for is a higher level of, in a sense, case management
Mhm.
and a little bit of social work kind of activity, which it might be within the ken of a lot of our providers, but it could also be something new to our providers. So it's the shift for the clinics is that we're still doing psychotherapy, and we're also doing a little bit of screening for social determinants of health, which means asking some questions. And then the obligation is to do something with the answers to those questions, which can include referring or not referring. And it also involves recording some demographics about who we serve. So those particular chores are going to take time. They may require a hire or some more labor, either contracting or intern or something. So what we're really trying to do at Combine is to really understand the impacts on the workday for the clinic administrator and for the clinicians to see whether, in some cases, this 50% increase in rates is actually sufficient to compensate for the additional work.
Right, right. Yeah. So I'm hearing like there's like almost some criteria to say, is this a fit for your clinic? I know a lot of group practices are looking at this to say, do we fit this model? So I appreciate you sharing. Like, there's going to be a lift here somewhere. There's an administrative piece here of like the screening and how do we make sure we categorize everything correctly? What else
Sure,
do people need to know?
sure. Okay, so along with this recording, we'll offer basically a 101 document about how you get started with this. So the first step in a thoughtful process is to read the rules of 502-1. So the BHA created a set of rules. It's got 12 chapters. And what clinics need to do is comply with the rules in order to stay in the Essential Safety Net Provider program. So there's a link to the rules. And the important chapters are Chapter 12, which is for the Essential Safety Net Provider program, although the later sections in Chapter 12 are for the Comprehensive Safety Net program. So the e-snip program is described in Chapter 12. Chapter 4 has the rules for outpatient clinics. And you'll see each of the following chapters focus on a different part of the continuum of care. Chapter 8 is for children and families. So if you're going to see children or families, you have to comply with the rules that are in Chapter 8 also. So a thoughtful decision is going to involve understanding what the rules are asking you to do. Okay. So the first step is to file a letter of intent with the Behavioral Health Administration, which is actually not a letter. So there's a link to the form. It's essentially just a form that says that you're expressing interest. And then you need to provide them with 2 policies and procedures. So the first one is Section 12.3.4, which is the no refusal policy. So we should talk a little bit about the no refusal policy and what they're really asking us to do and how we can refuse in some cases. And then the second thing that they want is your governance policy. So they want to know, how is the organization structured? Is it a nonprofit? Is it an LLC? How are decisions made? What's the administrative structure? And what's the ownership structure?
Right.
And then the owners that have 25% control or more need to be fingerprinted. So those are the initial steps in order to get what's called the preliminary license. And then the BHA will issue a letter that you then upload into Healthcare Policy and Finance portal, and you also let Healthcare Policy and Finance know that you've been approved by the BHA. And there's a link to that form in the 101 document. And then Healthcare Policy and Finance alerts the RAIs. So the RAIs get noticed that the BHA agrees and Healthcare Policy and Finance agrees that your organization is an essential safety net provider. And then you need to recontract or do a contract amendment for the e-snip rates. The e-snip rates are something that Combine's been working for 5 years, is a minimum rate for psychotherapy and for control of rate setting to be an open and transparent process. And so what the e-snip program has given us is actually a tremendous win for psychotherapy here, which is that we can anticipate our rates. The rates are public. They're in this, the state billing manual for July. Lists the essential safety net provider rates as an appendix. It's about 3 pages. And you'll see that a 90837 reimburses at $156. So that is, a 50% raise from some of the raise and a 25% raise from Colorado Access. So it's a substantial amount of money, and we need to put in some effort, right, in exchange for that compensation. Okay, so that'll get you in there. I think it's probably best to talk about no refusal now, which is an interesting part of the rules. And they have a bunch of categories for people that you can't refuse. So what the clinics have been writing the policies and procedures about is if a person is not going to be able to receive care from my clinic, then I do have the right to refuse.
Mm.
And that's what we call capacity and scope.
Okay.
So by defining the scope of your clinic, for instance, Boulder Emotional Wellness treats anxiety, depression, PTSD, and um, other maladies, but not substance use disorder. And we also refer out for domestic violence, and that has to do with us being a university training program. And so we very clearly delineated, drew a line around like what our scope is, right? We serve
Mhm.
this kind of client with this kind of treatment with these expectations. And then we also made it very clear what our capacity was. So we are willing to have some pro bono work, but we're not willing to have all clients be pro bono. And the BHA has agreed they don't want to write us into some kind of program where we're no longer financially stable. So one of the categories for no refusal is that you can't discriminate based on payer or ability to pay. So this raises a concern about pro bono work or people coming into the clinics and sort of saying they need treatment and then not being able to pay. So our response to that has been, if they're really unable to pay, then they're eligible for Medicaid. And
Okay.
our work at that point is to actually get them to peak, get them on the website, get them to their county health and human service enrollment, technical person, and get them enrolled in Medicaid. So there's a little bit of case management there of like,
Right.
okay, we're going to do this. If it turns out that their income is higher than is eligible for Medicaid, um, it's a little, one argument could be made is that they actually are able to pay, and they're actually not willing to pay.
Mm.
And we could discriminate based on that. So we're, you know, it's very early in the program. There hasn't really been a full discussion between the clinics and the Behavioral Health Administration about what the intention of no refusal is.
Right.
So I think what's really valuable right now is for the clinics to combine our efforts, and develop reasonable policies for ourselves that move the goals of the Behavioral Health Administration forward, which is really about this social determinants of health. So
Mm.
I'll say a little bit about that. Social determinants of health is something you can Google, SDOH or HRSN, health related social needs, and you'll see there's a lot of research about the impacts on people's health of not being able to afford heat, or not having access to nutritious food, or
Mm.
certainly housing challenges. And, there's a rising interest in how long term health outcomes are impacted by these health related social needs. And it seems fairly obvious that they are. And the usual example that we hear a lot about is diabetes and diabetes management. So
Mm.
we have a lot of people that are pre-diabetic or diabetic, and those situations are worsened if there is a lack of nutritious food or if there are housing challenges, like et cetera. So what the state is doing here is following the CMS, the Center for Medicaid Services, and the federal government, which is really supporting the idea that if we do something about health related social needs, we'll actually reduce the cost of healthcare. So
Right.
this is an ounce of prevention is worth a pound of cure, which is exactly where outpatient therapy lands. Like if we can have a competent and um, sustainable network of outpatient providers, we actually are very low cost treatment compared to medical treatments and compared to stays in the hospital.
That's right.
So it's important for us not only to be referral sources, but also to be referral targets. And so by being involved in the Behavioral Health Administration's e-snip program, where we're headed into is digital referral.
Mm.
So what we see is the BHA putting a lot of money. Also, there are various programs with the Office of Electronic Health Innovation to create what's called the Social Health Information Exchange for the state,
Ooh.
that are going to create infrastructure to do this referral and referral tracking. The BHA has already done this for available beds. So
Mm.
in residential or in hospital, they're now obliged to update their availability every 24 hours. So we know that they have the idea about how are we going to have an inventory of community-based organizations that we can refer people to? How are we going to outfit them with software? How are we going to have software? So that's where we're headed here. And the main implication is less work for the clinic administrators and less work for the clinicians if they have a system that actually makes it efficient
Mhm.
to ask social determinants of health questions. So, talking about screening for a second, um, they want us to screen for food, for housing insecurity, for safety at home, which is one of our existing screeners already, and a lot of clinics will already screen for if someone's safe at home, and a couple other items. Also, that item list can change. And so
Mm.
whatever, like it could change to, is there an educational component that they need, or do referrals cause other referrals to happen, or
Sure.
can can we only proceed with one kind of referral when this other referral is taken care of, right? Like we don't want somebody necessarily in referred to trauma treatment if they don't have a secure place to live, right? So some things have to happen before other things can happen. So
That's right.
this is all sort of where we're headed, and the obligations of the clinic administrators to kind of track this. So right now we have a model spreadsheet, which is kind of the um, lowest denominator technology here, where you just
Yep.
add a row for a patient and then you say, they answered yes or no to the screening questions. We referred them to this organization and they're part of these demographics. Now,
Mm.
there's an ask around the demographics that we want to alert the community to be a little bit cautious about. So they would like us to report if someone is or is not a member of the priority populations. So,
Mm.
in a sense, the clinics are obliged to be able to produce a report when asked or annually about the demographics of the clients that we see.
Mm.
And so they're interested how many of what percentage of our clients at Boulder Emotional Wellness are member of the priority population. So the priority population list is actually fairly extensive. So it
Mm.
includes all people of color, includes all LGBTQ, and it includes veterans.
Mm.
It includes people that are underinsured or publicly insured or non-insured. So it's essentially everyone that we treat except for straight white people.
Yeah.
Or in cis. So there it's an interesting thing that they're doing about priority population. We're not quite sure what they're going to do with those demographics, and I think it's
Mm.
important for clinicians when we're being told to collect data, like the C car, for instance,
Oh
to be
gosh. Yeah.
able to say to the state, if you guys are doing something meaningful with the data, we want to participate in that. But if you're not doing anything meaningful with the data, like we don't want to spend a lot of time collecting it.
That's right. Hmm.
So that's basically the program. We do have a working document that community members can contribute to, that's called the tasks. And what we're really trying to do here is outline, where what's the front end work, and then what's the ongoing work, right?
Sure.
So one of the concerns is having to write policies and procedures. We do have model policies and procedures for Chapter 12, Chapter 4, Chapter 8. And if you're trying to get your behavioral health entity license, which you don't need to be an e-snip provider, then we also have Chapter 2.
Mm.
So Combine's willing to share those, and then you can modify them for your clinic. So you have policies and procedures.
Amazing.
Now, the Behavioral Health Administration has backed off from requiring policies and procedures to be loaded into ladders. So,
Mm.
if you're used to working with the state, you might have run into this ladders database in the past where you would upload policies and procedures. Apparently, there's so much activity around this that they don't really have the bandwidth to read and approve. Our policy and procedures are like 60 pages. So
Right.
what I'm saying these days is we got to see those two policies and procedures for governance and for no refusal policies. And then you need to attest that you have policies and procedures, and you need to produce them if we ask for them. And you need to follow the rules. So it's a little bit more honor system right now. You can have your policies and procedures. And that's probably most of the front end work.
Sure.
The other areas that we want the community to participate in figuring out what our obligations are really are linguistic competence. So there is an ask that we have interpreters available, or that somehow we serve the community that's not English or is English as a second language.
Mm-hmm.
We are looking into the personnel file record maintenance. So one thing they're asking for is tuberculosis tests for all clinicians that are client facing in person. And we don't have a health infrastructure here that allows citizens just to go to a clinic. So we're trying to figure out ways to get tuberculosis testing done that's economical. There are some the tracking, the information tracking that I already discussed. You need to have your kind of basics around being a public clinic, like your grievance procedures need to be on the wall and they need to be on your website. You need to display the license. There needs to be an emergency exit map. Some of this stuff is trivial. Personnel and training, you need to document training, and you have to, a lot of these are just sort of best practices for a clinic.
Sure. I'm hearing
And there
that.
needs to be, there's a quality improvement program. There needs to be training in de-escalation. Treatment plans have to be reviewed every 6 months, which is already a Medicaid requirement, at least for most of the rays.
Right.
And then, but this document about the tasks that you're going to need to do if you participate in this program is available. And we'll
Thank
set
you.
up so anybody with the link can comment so we can have a discussion in there.
Awesome.
And yeah, I think that's the whole thing. So, really, getting involved with our clients on a clinical level of like, do you have enough to eat? Is actually a question that's outside of our general scope of practice. And so it is going to evolve a little bit of a culture change around how clinicians like interact with their clients. So this idea that we would get their demographic information when they call is actually not clinically appropriate. So we're pushing back on the BHA about, at that first phone call, we're going to ask them if they're gay is something we're not going to do. Or whether they have a disability or whether they're a veteran. A lot of these things take time to build rapport. So this is what we want to do as clinics right now is figure out how are we going to really support this program to do what they really want to do, which is, make the health of Coloradans better, So it's a good opportunity. Clinics should be doing it. And Combine's here. We have a directors meeting every other week to talk about implementation for the e-snip. And so that's all available. So thanks a lot,
Amazing.
Khara, for your time. And we have a couple minutes left. Do you have any questions?
Yeah, I want to say to the people watching this video after the fact that it sounds like, and I say this playfully, the plane is being built as it's flying. So as we record this, there might be things that will change, as it sounds like from what you've shared. So hopefully people can stay in touch with Combine, stay in touch with you, stay in touch with each other to say, hey, how's this going? How are we evolving as the parameters change with the feedback you're giving? So I just really appreciate everything you've shared. I know it's a lot of information. I'll make sure to link the documents below this video for folks who want more information. And I really just appreciate you, Andy. Thank you so much for your time today.